many of you who are wondering, so what exactly is health reform? I know a lot of folks were extremely confused. If you were like me on that Sunday, back on March 21, you were glued to the television. And what happened was, the House obviously passed the Senate Health Reform Bill that evening, and then right after, they had another bill, the Corrections Bill. That's that bill that took out the Nebraska Cornhusker kickback. You heard of Gatorade, you heard of those unfavorable provisions. So that actually amended the health reform law, and those together is what we call the health reform law. And then obviously President Obama signed it into law on the 23rd. I did have a slideshow here, a little cartoon, but I can't show you that one. It talks about there's a new report that looks at pre-existing conditions, and as you know, there are about 57.2 million now, we probably heard, who have a pre-existing condition. And again, I think that with many of the health insurance provisions in there, we're really going to be strengthening care and access for folks. Just to go through the side-by-side chart that I created, it looks something like this. It has Premier on the bottom. You'll see it says Public Law 111-148 as amended by that reconciliation bill. That's what we're going to go through briefly today. And then you should have also gotten, in addition to that, this color-coded chart. And that really is a complement to that first chart that we created. So if you are like me and you need to see things in color, here it'll show you if there's a particular section in there, let's say data collection for instance, and you want to know exactly when are those provisions going to go into effect. You can go on this chart and find the section number, and it'll tell you exactly when that will be coming into view as far as the regulations, etc. And then the other chart, if you are interested in the money, this one has funding levels as well as the implementation timeline, so you can follow along with that one. All right. As far as definitions are concerned, just want to bring your attention to two that I think are extremely important. One is the health disparity population, and the other is cultural competency. We tried to expand those within the Senate and House. Myra, I know, knows this very well. We were not successful. It retains the old definition, which was promulgated in the Minority Health and Health Disparities Research and Education Act that was signed into law by President Bill Clinton back in 2000. So those are just two to keep in mind. There was an attempt with the term health disparities to include healthcare disparities and to really expand that definition, to really strengthen it. Unfortunately, that was only in the House bill, and obviously the House bill didn't make it because of the politics. But there was that effort. So for those of you who have been following that closely and was wondering, well, is there a more consistent definition? No, there isn't, because of what happened. Now, as far as the health insurance exchanges, going on to health insurance now, those provisions, there are several provisions that I wanted to underscore. One is that there will be grant opportunities for folks to serve as navigators. And this is really important because these navigators are supposed to go into the community. They're supposed to basically help to raise awareness of the availability of these qualified health plans. And they're supposed to help with the enrollment of people into these plans. And one of the things that's really important about this is that these navigators have to provide information in a culturally and linguistically appropriate way that meets the needs of the populations that are being served by these health insurance exchanges to cover people. So that's absolutely critical, especially for folks with limited English proficiency. In addition to that, as far as health insurance exchange is concerned, the law also expressly requires that an enrollee's summary of benefits and coverage, as well as notices to enrollees of the appeals processes, both in internal and external, have to be presented in a culturally and linguistically appropriate manner. And if the point wasn't clear enough, the law, there was actually an amendment towards the MBA right before voting that stipulates that the plans and the exchanges have to submit information in plain language. And that's simply defined as language that the intended audience, including individuals with limited English proficiency, can readily understand and use. And as far as exactly what that means, if we flesh it out a little more, you're going to see that with the regulations coming up. So that's something to keep in mind. Moving on, in order to qualify as a health insurance plan in the exchange, a plan has to develop a quality improvement strategy to incentivize providers who implement activities to reduce health and healthcare disparities, including through the use of language services, community outreach, which also includes health literacy initiatives, as well as cultural competency trainings. So that's something to keep in mind going forward if you're interested in that. And then the last provision in that section that I wanted to bring your attention to really deals with the non-discrimination provision. Here, there was an attempt again with the House language to merge it with the Senate language that would have expanded and strengthened the provisions based on personal characteristics. So, for instance, if we're talking about gender identity, sexual orientation, those sort of things, we were really trying to strengthen those provisions for those individuals. And then we also wanted to make sure that the Supreme Court, which has really eroded civil rights protections for many racial and ethnic minorities, we wanted to really strengthen those as well. Unfortunately, that didn't make it in, so we just have the current law legal protections for you. But the language does extend protections to individuals who get coverage under these exchanges. So you have a right, a cause of action, a right standing to go and sue if you're being discriminated against in these health insurance exchanges. So that's I think that's absolutely important, nevertheless. Moving on to data collection now. In your charts, I'm sort of moving around a little bit here for the sake of time, but I think data collection is extremely important because if we don't have the data, we cannot track the disparities. And this was an extremely, extremely important win for us. I know many of you in the room who had been working together, all of us working together to really make sure that this stayed in. It was a problem with, even friends in the House and Senate and in the administration who, because of cost issues, wanted to strip this provision out. And we made the argument that you absolutely cannot do that. Of all the provisions in here, this is extremely important for us to really make the case for the disparity. So, with that said, the Secretary must now ensure that any federally conducted or supported healthcare program, survey, or activity collects and reports data on 5 variables. And these 5 variables include race, ethnicity, sex, primary language, and disability, including data on subgroups if it's practicable. And so there's that effort, that push to really go beyond just general race and ethnicity and get to those subgroups if we can. And any other data, demographic data deemed appropriate. Of course, we have that broad language in there. So if we need to push the Secretary to include other factors, we can do so. And again, long are the days when somebody can just look at you while, let's say, for instance, you're going in a hospital during the intaking process in the emergency department, and they make assumptions about your race. Oh, you look, whatever, and check that off. Now it has to be self-reported. They can no longer just make those assumptions based on how they perceive you. And for those who follow this issue very closely too, they also have to use the Office of Management and Budget Standards, the OMB standards, at a minimum for the race and ethnicity measures, and the Secretary will have to come up with other provisions to really look at developing standards around disability, around sex, and around primary language. And if you are involved with and taking care of people with disabilities, or you have a disability, I think you'll want to pay attention to this as well. There are special requirements for people with disabilities under data collection. One is that the Secretary now has to survey healthcare providers and establish other procedures in order to assess access to care and treatment for individuals with disabilities, and to identify 3 different things. One, locations where individuals with disabilities access primary, acute, and long-term care. 2, the number of providers with accessible facilities and equipment to meet the needs of the individuals with disabilities, including medical diagnostic equipment, making sure that those equipments are accessible to folks. And the number of employees of healthcare providers who are trained in disability awareness and patient care of individuals with disabilities. And there was also one final requirement that's worth noting within data collection, is that if they report any of the reporting requirements used for purposes of measuring quality, has to collect data on race, ethnicity, sex, primary language, and disability status.